Mild preeclampsia. Here is our case. 21-year-old gravida 1, seen in the outpatient clinic for routine visit at 32 weeks, confirmed by first trimester ultrasound. That's the same as our previous case. However, this patient complains of swelling in her hands and feet, but denies headache, epigastric pain, and visual changes. So she doesn't have those signs of severe preeclampsia. She's gained 10 pounds over 2 weeks. She should gain only 2 pounds in 2 weeks. So she's got increased weight gain. Her blood pressure is 155 over 95. That meets the criteria for hypertension. And it remains elevated 15 minutes later, shows she has sustained elevation of blood pressure. She has 3+ pedal edema, fingers are swollen, but the most significant finding is she has protein in the urine, 2+. No headache, epigastric pain, visual changes, mild elevation of blood pressure, and protein in the urine. That is consistent with preeclampsia. Gestation over 20 weeks, sustained hypertension, proteinuria equal to or greater than 300 milligrams in 24 hours, mild preeclampsia. A dipstick of urine is probably not as precise in terms of establishing proteinuria as is a 24-hour urine collection. And that's why we would prefer to do that. Less than 300 milligrams is considered not significant. 300 milligrams or more is. Notice the difference between gestational hypertension and mild preeclampsia. They both have their onset over 20 weeks. They both have sustained hypertension, but gestational hypertension has no proteinuria. Mild preeclampsia does have proteinuria. Demographics. Risk factors for preeclampsia, the most significant one is nullipara. A woman who has never gone beyond 20 weeks in her pregnancy has an 8 times higher risk of preeclampsia than a woman who's had previous term pregnancies. Age extremes, teenagers, advanced maternal age. Multiple gestation, we talked about that already. 3 times increased risk of preeclampsia. Molar pregnancy, now that's an interesting one because you can develop preeclampsia before 20 weeks with molar pregnancy. Non-immune hydrops. And notice these 4. Diabetes mellitus of long standing, chronic hypertension, renal disease, systemic lupus. What is it that ties these 4 together? Small vessel disease. Any patient who has small vessel disease, increased risk for preeclampsia. The pathophysiology is diffuse vasospasm. So throughout the body, the blood vessels narrow down. And that's one of the concerns, decreased perfusion. That can lead to capillary injury, and you can have then leakage of fluid from the intravascular space into the interstitium. Significant is that there are no symptoms. No headache, no epigastric pain, no visual changes. On exam, there really is no specific findings. Laboratory tests, what will we see? There must be protein in the urine to make a diagnosis of preeclampsia. 1 to 2+ or 300 milligrams on a 24-hour urine. And evidence of hemoconcentration. Instead of having the hemodilutional changes, such as a decreased hemoglobin, hematocrit, BUN, creatinine, and uric acid, we have a hemoglobin that's going up. It may be 13, 14. That's not normal. A BUN may be 15. A creatinine may be 1. Hemoconcentration we will see. What is a management for mild preeclampsia? If she is less than 36 weeks, we will hospitalize her inpatient and just conservative management until she gets to 36 weeks. The whole idea here is to give more time for el bebé. If she is 36 weeks or more, we want to deliver, and we want to prevent convulsions by using magnesium sulfate, and we will deliver her. No need for a cesarean delivery. We can have a vaginal delivery, and we want to continue the mag sulfate for 24 hours postpartum. This is magnesium sulfate. It is put on flowers. It is used to soak your foot if you've got a sliver in it. And many internal medicine people used to say, why don't you guys use a real anticonvulsant? The evidence, however, is overwhelming that magnesium sulfate in a head-to-head trial was better than phenytoin in preventing convulsions. If I had my way, I would rename preeclampsia, and I would call it diffuse vasospastic disease of pregnancy, because that's really what happens. Normally, you have vasodilation in pregnancy. That's why we have the drop in blood pressure, which normally and naturally occurs. But with preeclampsia, you have diffuse vasospasm. Instead of the blood vessels looking like this, they get constricted. Now, what is it that constricts the blood vessels like this? Not entirely clear, but there's good evidence that prostaglandins are involved. That thromboxane, which is a vasoconstrictor, goes up, and prostacyclin, which is a vasodilator, goes down. And that has led some people to think if we can suppress prostaglandin production with prostaglandin synthetase inhibitors, perhaps we can prevent preeclampsia. And some people have tried to do that using aspirin. Okay, and that is the end of mild preeclampsia.